Good morning, everybody. Thank you for joining. My name is James Griffiths. I'm a Senior Project Manager in the Value-Based Procurement team. Today, we're going to discuss value-based procurement with a specific focus on the procurement of a sacral nerve stimulator, or SNS device, for the treatment of fecal incontinence within Cardiff and Vale Health Board. The case doesn't contain all the answers to successful value-based procurement, and it does raise some questions. However, today I hope to help you challenge the traditional view of procurement and how we need to think and act differently if we are to implement value-based procurement as business as usual. Please use the comments panel to raise questions, and I'll respond to them at the end of the presentation. The structure of the following presentation is based around, firstly, a look at the context and the situation, then a brief outline of the solution, then some more detail on what we did, and then some lessons learned. So, beginning with the situation and the context, it's estimated that 1.4% of the population experience regular and severe fecal incontinence that greatly affects their quality of life. Patients can experience multiple daily episodes, up to 7 a day. The social and economic issues surrounding this condition are severely detrimental to the quality of life for the patient and their families, often resulting in relationship breakdown, financial hardship through loss of job and reliance on benefit income. A nice recommended treatment for severe fecal incontinence, or FI as I will use from now on, is sacral nerve stimulation, SNS, where conservative management has not improved outcomes for patients. By conservative management, we mean such things as dietary changes, pelvic floor exercises and medication. It's important to note also that SNS can help avoid more invasive, irreversible and body-changing operations, such as the formation of a stoma or a colostomy, that you can see on the right-hand side of the arrow there. SNS uses a programmable neurostimulator to reduce or eradicate episodes of incontinence. A patient progresses to implant after a successful 2-week trial period using a test device above the skin. This way, normally only patients who are most likely to benefit from the implant progress to the actual operation, and this is an important point. The treatment was outsourced to England, where SNS has been available in the other home nations for over 15 years. As for the causes, there are many. Fecal incontinence can be caused by surgery for cancer or radiotherapy, which affects both men and women, but the greatest cause is obstetric injury, so trauma through childbirth. We anticipate the annual demand to be around 150 patients across Wales, but there could be many more suffering in silence because this is not necessarily a condition that people talk about. So, a brief overview of the solution. Having carried out a successful operations as proof of concept in Cardiff late 2018, the solution saw an investment in a coordinated patient pathway, ensuring patients have complete conservative management before progressing to SNS as a treatment option. In addition to this investment, an industry partner entered into a risk share value-based procurement contract that means the SNS device is paid for after 12 months of use, provided there is evidence of an agreed level of reduction in the frequency of FI episodes and an agreed level of improvement in patient-reported quality of life relative to their pre-operation baseline data. It is important to highlight also that significantly improved quality of life from a successful SNS operation also brings significant wider socio-economic benefits that go well beyond the initial cost and the more tangible benefits. So, we started with some early scoping and engagement with different stakeholders to get their perspective. Early clinical engagement with key colorectal surgeons highlighted the need for improvement and that treatment with the SNS device was required. This helped to start to build the case for change. Engagement with wider stakeholders across the health board at this early stage helped establish who can help bring about change and also helped with a deeper understanding of the potential wider benefits. Pre-existing evidence from other studies across Europe and elsewhere was also helpful. It helped build an early case for change. For example, SNS has been demonstrated to be a cost-effective treatment with an incremental cost effectiveness ratio, or ICER, of 25,000 per QALY gained. It's also been shown to be more cost effective compared with other surgical treatment. For example, a study by Hertzer 2006 concluded SNS to be more cost effective than stoma formation or gracioplasty. Tiandra 2008 concluded that for the right patient, SNS was more effective than conservative management. But very importantly, and after a more thorough study of the evidence and an in-depth technology appraisal, SNS was also supported for adoption by Health Technology Wales, who in June 2018 concluded SNS guidance should be adopted or justification given as to why it has not been. So from early scoping and building an outline case for change, we progressed with a more in-depth mapping and analysis within the Health Board. This comprised of several steps to ensure as rounded and as full an investigation as possible. Each step looked to better understand the value potential, i.e. to establish the opportunities to reduce costs, whilst also improving outcomes that matter to patients across the cycle of care. Important to point out that we were looking at potential value, so not process efficiency in isolation. We had to be able to establish efficacy and a positive impact on patient outcomes. So the bottom and top halves of the value equation within the context of the Health Board. We will look at each of these steps in more detail in the following slides, but the approach really involved patient engagement, detailed pathway mapping, a costing of the current situation or as is, identifying areas of waste and unwarranted variation with the stakeholders, and then elaboration and costing of a potential 2B pathway. So starting with patient engagement, this gave a first-hand understanding of their condition and was very powerful in evidencing the need for change. Trial evidence, as mentioned previously, helped establish a case for change, but adding that human dimension offers the opportunity for invaluable insights, and it did so in this case. Speaking to Welsh patients also helped further contextualise and bring the issues much closer to home. The insight gained from patients highlighted the terrible impact of this condition, but also the potential that successful treatment has to improve outcomes that matter to patients. These actual comments from patients pre-treatment clearly show how it can impact their quality of life and that of their wider family, such as they had a fear of going out, unable to do the school run, significant mental stress leading to depression, impacting on work, disturbed sleep, and many other horrendous issues. As you can see, just a few from the slide there. So having engaged with patients, we moved to a more detailed pathway mapping of the current situation, the as-is. We met several of Cardiff and Vale patients and the clinical team and constructed a detailed pathway map of the current situation. With help from finance at Cardiff and Vale, the finance delivery unit, the procurement teams and the colorectal surgeons, we were able to calculate costs of procedures, length of stay, product consumables and prescription costs, these multiple layers to show the current costs of the Health Board. This gave us a better understanding of the cost along the patient pathway relative to the current patient outcomes. Techniques for costing included a combination of TDABC, time-driven activity-based costing, and patient-level costing PLICs. You may have seen more information regarding these techniques in presentations earlier this week. One patient pathway, admittedly one of the worst cases, you can see on the left of the slide there, served to evidence the very poor outcomes and showed that the current situation was really far from a sustainable model. This particular patient had suffered severe fecal incontinence for over 15 years, and it's worth bearing in mind that the longer it takes to treat this condition, the more problems are likely to arise. Okay. There were 8 episodes of incontinence per day, using upwards of 4 pads. They lost their job as an outreach worker. Their marriage was damaged. They even had to move house to be closer to their son's school to avoid an episode whilst on the school run. Really a very, very poor quality of life there. And in terms of treatment and interventions along the pathway, this patient had had a significant number of appointments and procedures. We counted 38 secondary care appointments, inpatient procedures where they had to stay in hospital, 4. In total, 29.5 days in hospital, and having to deal with across those years 5 consultants. So, very poor outcomes for a very, very significant cost. So then, in terms of the 2B, a future potential pathway was mapped and costed with successful SNS treatment in Wales. It was clear that there was a real opportunity to significantly reduce total costs, compress the total time for the right patients to reach SNS treatment, while significantly improving the outcomes that matter to those patients, as you can see from these 2 slides. So drawing upon the wider historical evidence and a more focused local mapping, the as-is and the 2B, we were able to estimate the longer-term value to the health board. The slide shows the estimated cumulative cost of SNS versus conservative management across 5 years. This is important because it helped to see SNS treatment less as a cost to the secondary care budget and more as an investment that would yield benefits across the health board in both secondary and primary care settings. So in addition to significantly better outcomes for the patient, there was also less demand on prescribed products across several years. So then we move to the proof of concept trials. After these trials, in Cardiff Vale 2018, early 2019, the patients reported very positive outcomes. The experience of the operation also helped us to better establish the costs of the procedure in a local setting, and we were able to establish that this would be 30% less expensive than subcontracting to England. And it is believed that further experience, as we carry out this operation more frequently, will see further cost reductions without a negative impact on patient outcomes. The actual patient comments speak for themselves, as you can see from the slide above. It was life-changing. They can sleep at night. SNS gave a light at the end of the tunnel. It made a massive, massive difference. These are really, really positive outcomes for the patient, as evidenced carrying out the operation in Cardiff. So, firm early engagement with patients, clinicians, Health Technology Wales, finance and suppliers through more detailed mapping showed that there was clearly an opportunity to adopt a value-based approach, significantly reducing costs across the cycle of care, whilst at the same time improving effectiveness through a marked improvement in outcomes that matter to patients. The challenge for value-based procurement was then to partner with a supplier to let a contract that was based on real-world patient outcomes, as opposed to a more traditional arrangement that would have seen payment for the device upfront and before outcomes were known. Traditionally, negotiations might have been more focused on price as opposed to outcomes. So this was the challenge, to shift the conversation and the focus with the supplier. So how did we do it? We partnered with Medtronic, and the objective was to establish key performance indicators within the contract that were based directly on the improvement of patient outcomes, with efficacy as a central driver. The device is paid for after 12 months and upon evidence of improved outcomes using established and recognized outcome measures. So these were criteria 1, the number of incontinence episodes per week needed to have reduced by 50% or more. And this is a well accepted and established measure of success in both random control trials and in practice. Criteria 2, the International Consultation on Incontinence Questionnaire, or ICIQB, we had to see a mean reduction of 2 or more across the 3 domain scores. The 3 domain scores relate to bowel control, bowel pattern, and the quality of life. The third criteria, the Rockwood Fecal Incontinence Quality of Life, or FEQUAL, questionnaire, and here we needed to see an improvement in overall score of 0.4. So some quite rigid but clear and defined criteria and improvement to meet. And finally, treatment satisfaction questions. If the patient would recommend this treatment again, would have this treatment again, and if they would recommend this treatment to others. Yes to both of these questions. So to summarise, the approach to building the risk share arrangement with the supplier saw several steps. There was an agreement of the improvement criteria to measure, so we had to convene on that. There's agreement on how and when these criteria would be measured. And then we needed to agree on the expected improvement above the baseline that would trigger the payment, as detailed in this slide. And interestingly, the type of arrangement also, in this case, it linked to the cost of the device. So it's paid for 12 months after implant, provided we get specific improvements. But we are seeing other models emerging, and we're very open to exploring these. And these models take into account other areas of cost for the care provider. So not just the cost of the device, but the cost of implanting the device or any device that fails is also being compensated in these cases. So in summary, early scoping of the context, possible stakeholders, evidence and benefits sought, so building the case for change, then some in-depth mapping and quantifying of the current situation and opportunities to deliver value. And then it's a question of selecting key criteria for improvement with the supplier and the clinicians for value delivery upon which you can base the contract. And then you move to the implementation phase with the supplier. So I think this case study is a relatively small scale, but in terms of thinking big and starting small, which is this has served as a valuable learning opportunity with both positive and negative aspects. And I'll touch upon a few here. So what went well? Patient engagement proved absolutely invaluable for understanding the issues and gaining insight into the outcomes that matter to patients. I mean, really, who else is better placed to give you that insight? They are our reason for being, so let's engage. Clinical support and insight is critical. And in this case, what went well? Surgeons saw procurement and the procurement team at Cardiff and Vale as an enabler, somebody there to help, rather than a barrier to getting something they wanted, and that was very important. Also, the supplier was open to risk share arrangements. They were keen to engage on that level. They were keen to move away from price because it's not sustainable for them and it's not sustainable for us. So we didn't have this adversarial price-based negotiations. We were able to align on outcomes that matter to patients, and that was a shared goal, very important. Also, I need to point out the head of procurement at Cardiff and Vale was very experienced in value-based procurement and was integral to the process. So a few things didn't go so well, but they served as valuable lessons. Pathway maps and associated costs are a prerequisite to understanding opportunities, but it takes time and resource to map a pathway and cost it effectively. And this information isn't at your fingertips yet. So it takes time and resource. In this particular example, patient diaries and the questionnaires are all paper-based at the moment. So additional resources required to manage that process. And you can have issues with completion and return. There's no guarantee that a patient is going to be able to or willing to complete the questionnaires. Also, it can take time to refine a business case and get it signed off. All parties need to buy into the idea of value. So when the business case is presented, you're all talking the same language. And in this, we learned some valuable lessons there. Also, I alluded earlier to the socioeconomic benefits of positive outcomes. These are significant. And in this case, if somebody can't leave the house, they can't do their work, they're claiming benefits as some patients had to. That has a cost, and when they're able to get back to work, that also there's a benefit there. But it was these benefits don't lend themselves to process-driven, operationally focused TD-ABC and patient-level costing. They require more, more health economics expertise that is needed. So key learnings: clinical, financial, and patient engagement is key. They need to be involved from the start. VBP requires, so value-based procurement requires a more in-depth knowledge of the wider care pathway and associated costs. But this insight, it can't be attained by procurement in isolation. Procurement cannot act alone to bring about that change. There's a need, I guess, for a multidisciplinary approach, as procurement takes on more of a strategic role than a reactive one. Also, that the power and insight of the patient perspective and stories is invaluable. Okay, so in terms of the lessons learned around the contract outcomes, keep it simple, as simple as you can to start with, and build from there. Focus and build trust with the supplier and other stakeholders around the metrics that the supplier is happy to work with. And I think in this sphere, at the moment, a direct link as possible between the product or the service and the outcome is a good place to start. Be mindful of other dependent and interrelated projects or workflows. For example, I'm working on a project at the minute that will hopefully end in conclude in a value-based procurement and outcome-based contract, but there are other areas of work that need to happen and need to be completed. For example, the service needs to secure space to deliver the service in question, and other things need to happen for the contract to be effective. So keep those interdependent projects in mind, I guess. It's important to approach procurement for product or service as an investment rather than a one-off cost, and this investment can yield positive outcomes across time and across different settings that outweigh the initial cost, and thinking in that way can help us find more financially sustainable solutions. So to summarise, why value-based procurement and why is it important and what have we learned from this? Well, it's financially sustainable. Its financial sustainability is improved. It aligns and supports the delivery of value-based healthcare, promoting effectiveness and positive patient outcomes. And it promotes a longer-term supplier relationship versus this short-term adversarial relationships around price that, although they have their place, can in some cases not be sustainable. So I'd like to thank you for listening. That brings me to the end of my presentation. I believe there are potentially some questions, so we have some time to answer questions here. I hope you enjoyed the presentation. Okay, so going to the questions. One of the challenges in letting more arrangements based on outcomes is trust. What do you think are the solutions in gaining more trust between buyers and suppliers? Well, I think that the trust is founded upon firstly talking the same language. So suppliers and procurement professionals need to be thinking in terms of value. The trust comes from doing and learning together. Being partners rather than adversaries. I think you can build a relationship that way, and trust will come from having evidenced projects that work, and trust is founded on the data. So all having trust in the data and all agreeing the metrics that you wish to measure, and all agreeing, I guess, reasonable improvements linked to patient outcomes that can be rewarded. So yeah, trust is built on experience and good quality data that links to the patient over time. Okay, another question. How difficult was it to agree the specific outcomes that would be linked to payment? Okay, I mean, this project was perhaps easier than others because I mentioned it at the start of the presentation. Patients that have the implant, so they have the surgical intervention, they first go through a 2-week trial period with a similar device that's placed above the skin. So the supplier in that respect was, and the clinicians, that they're more confident that the patient that goes forward to the implant, it's going to be successful for them. So that kind of eased the way a bit, and then refining, what criteria, what outcomes we would work upon. That was helped by the fact that there were these accepted and used patient diaries and quality of life questionnaires already in use. So we were just building upon something that was already there. So that was very helpful. It would be more difficult if they weren't there and you didn't already have those mechanisms on which you could build. So another question. Thank you for these. Are you able to share how much the agreed pricing varied depending on the scores from the patient? How big was the range? Okay, that's a good question. The price for the device was set. What was in question was the timing of the payment based on the positive outcome. So the price didn't vary in that respect. So did you encounter any legal challenges on the way to agreeing a way forward? We didn't have any legal challenges, but there are, it's a new area. I suspect when we start expanding this practice, there could well be. There are, procurement procedures to follow and standard financial instructions to adhere to. So I think for as long as we adhere to due process, then we should minimise that risk, but I think there's always a risk of that. Thank you. Another question. How challenging was it to gain the clinical engagement that you needed for this exercise? Actually, in this example, it was relatively easy. The clinician was really motivated to get this up and running. So that really helped. In other areas where we haven't had clinical buy-in at the start, it's been a bit more of an uphill struggle. But in this instance, it was relatively easy because the clinician was, really motivated by doing this. But I've been in other conversations with clinicians, and initially, when you start talking value-based procurement, the conversation goes along the lines of yes. Well, you're just trying to take money off my budget. And at the end of the day, that's what you're here to do. And you have to convince them, no, we're not here to do that. We're here to help you achieve your aims and to do more with your limited resource. That's what we're all trying to do. It's not we're not trying to take money off you. Okay. Another question. It seems critically dependent on having robust electronic outcome platforms. Is the expansion of the program dependent on this? Yes, I think that you've hit upon a great point there. Paper-based to start with, fair enough, quite small volumes, somebody already there to do it. The moment that starts to escalate, and there are discussions happening around this, that needs to be a digital solution really. Not only in terms of collecting the pre-operation, pre-implant baseline data, the patient diaries and quality of life questionnaires, but also in terms of collecting them afterwards, and on a bigger scale, linking the payment to the outcomes. If that could be digital, that's really going to help promote this more widely, I think. So yeah, good question. Electronic outcome platforms can really help. Is one of the things that can enable expansion of this type of approach, I think. Okay, so I think we seem to have come to the end of the questions. Thank you very much for listening and engaging. If you have any more questions, please feel free to send me an email. But at this point, I should highlight that the Value in Health continues for the next 2 days, and there are some very interesting presentations yet to come. So please take a look at the program. If you haven't already enrolled, there's time to do that. And thank you very much for listening.